Right. Thank you, everyone, for joining us tonight for the Maryland, D.C. Society of Addiction Medicine in part 2 of our Autumn CME series titled Ambulatory Alcohol Withdrawal Management During COVID-19. The Maryland, D.C. Society of Addiction Medicine, the combined regional chapter of the American Society of Addiction Medicine, serves our members through advocacy and education, and our work and mission are supported through members who join ASAM. This week is National Addiction Treatment Week, an initiative launched in 2017 by ASAM, which promotes that addiction is a disease, evidence-based treatments are available, and recovery is possible. This week also highlights the need for clinicians to enter the field of addiction medicine, as there is a critical gap between the number of patients who need addiction treatment and qualified medical professionals available to treat patients using evidence-based practices. So if you like this webinar and want more content like this, please consider joining ASAM at www.asam.org. For those of you who do not know me, my name is Scott Wetzel, and I am a physician that serves on the MD-DC-SAM Program and Education Committee. I'm a practicing addiction medicine physician in Washington, D.C. However, I did my residency training in pediatrics, but transitioned to addiction medicine about 2 years ago. And I primarily provide opioid-based office treatment through my private practice, but I serve as medical director at PIDARC, an opioid treatment program in Washington, D.C. As a reminder to you all, this call is being recorded and we will post it on our YouTube channel in a series of clips for everyone to access. And we have muted participants at the beginning of this call for sound quality purposes. However, we do welcome your questions, and you can submit them via the chat feature, or if you're joining us by phone this evening, you can unmute yourself during the Q&A portion by pressing *6. At the end, I will summarize all the questions that were posed and present them to our speakers. COVID-19, as you all know, has brought about unprecedented changes to how we approach substance use disorder treatment. We understand now that COVID-19 highlights the inequities and inequalities that already plague our patients, from access to high quality treatment, housing, jobs, and criminalization. Our patients are also struggling with reduced access to group meetings, the loneliness and boredom of social isolation that can lead to a recurrence of substance use, and limited access to community services. We are all working very hard to protect our patients and ourselves from the risks of COVID-19 by promoting physical distancing, altering treatment schedules, and reducing face-to-face encounters while implementing telehealth visits. I'm hopeful that the following presentations and discussion will support us as a treatment community to continue making improvements for our patients during this very trying time. This evening, we are very fortunate to have nationally recognized leaders on the call tonight who are committed to bringing the latest guidance from both ASAM and the state of Maryland to our members. Dr. Anika Alvanzo, a distinguished fellow of ASAM, will start us off with an overview of the updated ASAM guidelines on alcohol withdrawal management. She is the Eastern Region Medical Director for Pyramid Healthcare and the immediate past president of the Maryland, D.C. Society of Addiction Medicine. Following Dr. Alvanzo, Dr. Brian Hurley, also a distinguished fellow of ASAM who serves as the Director of Addiction Medicine for Los Angeles County Department of Health Services, will provide a deeper dive on how COVID-19 has impacted ambulatory alcohol withdrawal management. Both of our speakers tonight have been instrumental in drafting ASAM guidance on alcohol use disorder over these past few but long months. Dr. Alvanzo.
Good evening. Can you all hear me?
Yes.
Okay, great.
Yes.
So let me start sharing my screen. And while this is getting going, just wanted to thank MDDC-SAM for the opportunity tonight to speak with you. Let's see, is it taking a little while? Okay. All right. So as you know, earlier this year, ASAM released updated guidance on alcohol withdrawal management. They actually released the guidance earlier than was anticipated as a result of the COVID-19 global pandemic. And so it's a very detailed document. I encourage you to all to look at it. You can find it on the ASAM website. If you just type in ASAM, alcohol withdrawal management, you'll get right to it, and you can download the full document on the website. For tonight, I had the opportunity to participate as part of the guideline committee. And tonight I'm just going to talk specifically focusing on ambulatory alcohol withdrawal management. Okay. So these are my disclosures, I think was already stated. And these are the learning objectives for tonight. I'm hoping by the time that we're done, you'll understand the process that we actually went through to actually develop the guidelines. I'm going to describe very briefly the assessment and risk stratification of patients with alcohol withdrawal syndrome, again, focusing specifically on which patients are appropriate for management in the ambulatory environment, and then discuss, again, very briefly, pharmacotherapy for alcohol withdrawal in the ambulatory setting. And then Brian is really going to focus on adaptations of this in the era of COVID. So as you are sure all aware, just want to provide some background on kind of why we're talking about this. So we were already in the midst of an opiate epidemic prior to the onset of COVID. And with COVID, we've seen a dramatic increase in overdose deaths. And typically those deaths are, we think about opiates when we think about those deaths, but this is actually data from the Maryland specific data from the Opioid Operational Command Center. And what you can see is at the top, this is comparing data from January to June of 2020 versus the same time period for 2019. And what you can see is that essentially, with the exception of PCP, we've seen a rise in overdose deaths associated with essentially all substances that can be misused. But particularly, there's been a 35% increase in alcohol-related intoxication deaths in the state of Maryland. And so I think this just highlights the importance of why we're focusing on alcohol tonight and management of specifically alcohol withdrawal. So just to talk a little bit about the epidemiology of alcohol withdrawal syndrome, it's estimated that approximately almost a third of people in the United States will develop an alcohol use disorder in their lifetime. So about 29% lifetime and about 14% in the previous 12 months. Almost half of patients with alcohol use disorder will experience clinically significant withdrawal symptoms. The overwhelming majority of those people will have either mild to moderate. But it's a small proportion of those patients can actually go on to develop complicated withdrawal. And that would include seizures and alcohol withdrawal delirium. And when untreated, we know that alcohol withdrawal syndrome can be a fatal disease. So I just want to talk a little bit about kind of the process we went through for guideline development. So this was a multi-year process. So this process actually started in 2017. And just to give you a little bit of the rationale for why it was determined that we needed to update the guidelines. So the last guidelines were actually published in 1995. Was the last time prior to this when ASAM released the guidelines on alcohol withdrawal management. ASAM has a Quality Improvement Council, and a number of things happened that led the Quality Improvement Council to recommend updating the guidance for alcohol withdrawal. One, they did an educational needs assessment that identified this as an area in which people wanted more information. They refined their policies, which actually recommended that guidelines be updated every 5 years. The APA released a guideline on medications to treat alcohol use disorder, but didn't include anything on withdrawal management. And they did some outreach to other organizations, and was nobody who was planning to release any guidance on alcohol withdrawal management. So this was a gap that the QIC determined needed to be filled. So in terms of the process for developing the guideline, it was actually a hybrid of established methodologies that were used to develop the guidelines. So they used the Veterans Health Administration and Department of Defense guideline for guidelines in terms of developing the scope and then determining which how to draft the statements. And then they used the RAND UCLA method, which is a method that determines how you rate and refine the draft guidelines. It's a specific process for combining the available scientific evidence with the clinical judgment of experts. And so you can see there was the scope development, then there was a literature review, draft statements. You try to get some consensus, draft guidance document that was then posted for comment, and then external review. So this is, again, the main component. So I already talked about the QIC and their involvement in initially deciding that this needed to be done, but they also served as the oversight committee for the process. So they provided guidance on the scope and the intended audience for the guidelines, and then they identified clinical champions. And the clinical champions kind of helped to refine the guidance and specifically provide more information about the scope and identify questions of greatest clinical importance. So when they started off, they initially had 2 clinical champions. But I can tell you, again, this was an iterative process. And after our first meeting of the guideline committee, it was determined that we really needed to focus on ambulatory withdrawal management. So it kind of went back to the board, and they added 2 additional experts who had specific expertise in the area of ambulatory withdrawal management. So you have the clinical champions. We worked with IRETA, which was the company that actually provided the research and technical assistance. They did an extensive literature review, including the published literature and the gray literature, and they focused on literature that was published between the 5-year or 6-year period of 2012 to 2017. And then they generated, based upon that extensive literature review, they generated a draft list of guideline statements. And then I was part of this multidisciplinary expert panel. There were 9 of us who met multiple times. So first time face-to-face, and then we had multiple kind of virtual meetings where we reviewed the draft guideline statements. And then, as I said, after that first meeting, we realized that there was a gap in terms of inclusion of guidance for the ambulatory setting. And so, again, went back into another round. So this was an iterative process that, again, started in 2017. And as I said, the guidelines weren't published until earlier this year. So just to talk a little bit about assessment of alcohol withdrawals. I'm not going to say a lot about neurobiology. What I will say is that what we know about alcohol is that it hits a number of neurotransmitter systems in the brain. And that's probably why our medications are not as effective as those medications as the medications for opiate use disorder, because of all of the targets in the brain. But what we do know is that alcohol particularly interacts with the GABA and the glutamate system. So GABA is the primary inhibitory neurotransmitter, and glutamate is the primary excitatory neurotransmitter. And what happens with chronic alcohol use increases GABA activity and decreases glutamate activity. But what happens with chronic use is you get upregulation of glutamate receptors in the background. And in the absence of alcohol, or with reduction in alcohol, now you've got this increased excitatory activity that contributes to what we know as the alcohol withdrawal syndrome. So these are some of the signs and symptoms of alcohol withdrawal syndrome. So certainly you can have mild withdrawal, includes anxiety, tremor, insomnia. You can have gastrointestinal symptoms, including nausea, vomiting, alcohol hallucinosis. And I just want to make the distinction between alcohol hallucinosis and alcohol withdrawal delirium, because sometimes people conflate them. Alcohol hallucinosis is a syndrome where patients have hallucinations, but the sensorium is intact. So they may be feeling strange things, seeing strange things, or hearing strange things, but they are able to, the sensorium is intact, and they're able to know that what they're experiencing is not normal. And then as you move down, you can have moderate to severe withdrawal. And you can see on the chart, it kind of gives you the typical timeline for when you might expect onset of these symptoms. You can have withdrawal seizures. And the thing to know about seizures is that they can actually occur very early in the course of alcohol withdrawal. They're typically a single, isolated, generalized tonic-clonic seizures, but you can, in rare cases, have status epilepticus in the setting of alcohol withdrawal. Peak occurrence for seizures is usually within 24 hours. And then we get down to alcohol withdrawal delirium, or what people typically used to refer to as delirium tremens, or DTs. So alcohol withdrawal delirium is where patients are not, their sensorium is not intact. They are delirious, and they have a number of other symptoms, including the presence of autonomic instability. So often blood pressure instability, tachycardia, severe agitation, and then this is actually, if untreated, can be fatal. So in terms of initial assessment goals when you're working with a patient who has alcohol withdrawal. So one, you want to really orient your assessment towards evaluating the risk. So what is the risk of developing severe or complicated alcohol withdrawal? And we'll talk specifically about what that is, because those definitions changed a little bit. I can tell you, prior to the release of the guidelines, when I said severe alcohol withdrawal, I was thinking of somebody who had seizures or alcohol withdrawal delirium. But with these new guidelines, that has changed somewhat, and we refer to that more as complicated alcohol withdrawal. You're also assessing for the severity of presenting signs and symptoms, and then you want to know certainly what symptoms do they have, what signs and symptoms do they have, what is the likelihood that those symptoms are going to escalate, what is the trajectory, and can we potentially alter the trajectory by medication, but do they have other risk factors that may increase their likelihood of developing severe or complicated withdrawal, and use that information to then guide us in terms of what may be the most appropriate level of care for patients. So in terms of choosing a tool, there are a number of different clinical assessment tools for managing, for assessing alcohol withdrawal, and then using not only to assess the severity, but then also to determine the effectiveness of your management. There is not one preferred tool. So most commonly you'll see the CEWA or the CEWA-AR, but the guidelines did not pick one specific tool. There's not one preferred tool. We just want you to use a validated tool and make sure that you're choosing the tool that's going to be most appropriate for your setting. And that you're using the tool not only to assess the patient at the moment that they present, but then also use the tool to guide and to determine how effective your management is. So these are some of the tools: the CEWA, AR, the brief alcohol withdrawal scale, or the BALS, the short alcohol withdrawal scale, or the SALS, which is actually a tool that was designed to allow for patients to do kind of self-assessment. So again, this might be a tool that if you can educate your patients on how to do it, might be appropriate for ambulatory withdrawal management. And then the RAS, or the Richmond Agitation Sedation Scale, which is probably something that may be more commonly used with patients with severe alcohol or withdrawal or complicated alcohol withdrawal when we're talking about sedation and looking to see how they're sedated. So this is how they categorize the signs and symptoms of alcohol withdrawal syndrome. And again, you'll see here, so mild is considered a CEWA AR less than 10 again, and note that they use the CEWA in the guidelines. So if you're using a different tool, you're going to kind of have to get a sense of what the comparable ranges for your tool is, or are, I should say. So for mild, a CEWA score of less than 10, moderate considered a CEWA score of 10 to 18. So patients may have some anxiety, sweating, insomnia, and mild tremor. Scores of 19 or higher are considered severe. So that's somebody with severe anxiety, moderate to severe tremor, but no evidence of confusion, hallucinations, or seizure. Once somebody's had a seizure, or certainly if they have any evidence of delirium, then they're considered complicated alcohol withdrawal. So when we're looking at kind of level of care considerations and trying to figure out where this patient might best be treated, you want to obviously look at the current signs and symptoms. You want to look at the level of risk, and particularly their level of risk for progressing to complicated withdrawal. And then what are other dimensions? So what is their recovery capital? What's their environment? Are they in an environment where if you do send them home, they're going to be able to take and manage medication, or is their environment too chaotic for that to be a reliable option? The rationale is that, according to the ASAM criteria, we want to be able to treat patients in the least restrictive setting, but also that is still safe. And so obviously the greater the risk, the greater need for more intensive monitoring, but we recognize that we can potentially mitigate that risk with medication. So when we're looking at the ASAM levels of care, there's two levels in which you can do ambulatory management of alcohol withdrawal. So you've got the level 1, which is considered ambulatory withdrawal management without extended on-site monitoring. And the best example for this is like a primary care office. So a patient comes into their primary care office, they've got evidence of mild alcohol withdrawal, and they've got a stable place to go. They've got someone at home who can assist them with monitoring and help make sure they take their medication. No history of complicated withdrawals in the previous year. And they've got mild symptoms. This may be somebody who might be appropriately managed in this setting. And then you've got level 2, ambulatory withdrawal management with extended on-site monitoring. And so the best example for this is something like a partial hospital or an IOP setting where patients are going to be at the clinic for an extended period of time during the day so that there are eyes on them for extended period of time during the day. There's daily contact. And it's often able to be located with, co-located with treatment and access to other support services. So going back to that, this categorization of signs and symptoms. So obviously people with complicated withdrawal are not appropriate for ambulatory management. And then for severe withdrawal, there may be instances in which patients in severe withdrawal can be managed in a level 2 setting. They're not appropriate for the level 1 setting where they're not going to be seen daily. Potentially could be managed in a level 2 setting with clinicians who are experienced in the management of withdrawal. So in terms of pharmacotherapy, your management goals, obviously you want to ameliorate signs and symptoms of withdrawal. You want to prevent progression of their withdrawal syndrome, ensure that they're safe. Ideally, you want to address any associated health problems or other health problems that the patient has. And then you want to support successful transition to initiation of treatment for their alcohol use disorder. So for medications, and these specifically, again, for monotherapy, the medications that are listed in the guideline include, and specifically we talked about the impact of alcohol on the GABA and glutamate system. So these are medications that are going to target one or both of those symptoms. So benzodiazepines are still considered the medication of choice for most forms of alcohol withdrawal syndrome. They tend to be appropriate for patients in essentially all of the different levels of care, and they have the most empirical evidence in terms of effective management of alcohol withdrawal. Phenobarbital, again, phenobarbital certainly has indications. If there's somebody who, for some reason, benzodiazepines are contraindicated or they're not responding to benzodiazepines, then phenobarbital may be an option. In the guideline, we specifically said that if phenobarbital is being used in the ambulatory setting, it should only be done by clinicians who have training and experience using it, because phenobarbital has a much narrower therapeutic window and more opportunity for patients to get into trouble. And so if you are in an ambulatory setting and don't have experience with this medication, then I would avoid it. And then the one thing I think that is new in this guideline is that specifically the highlighting of the effectiveness of some of the GABA-sensitive anticonvulsants, particularly carbamazepine and gabapentin. These are appropriate for mild, as monotherapy, meaning using them alone for mild to moderate withdrawal. They're not appropriate for severe and certainly not appropriate for complicated withdrawal as monotherapy. They are beneficial as adjuncts in those situations, but not for monotherapy. But certainly for mild to moderate withdrawal, they can be used as monotherapy. And you have to kind of figure out kind of your own practice, what you think may be the best to use. If you're thinking about using gabapentin as an option for treatment of alcohol use disorder, then maybe that's the most appropriate one to start for management of alcohol withdrawal. Then you can just transition them to ongoing maintenance. Compared to benzodiazepines and phenobarbital, both of these medications have a better safety profile. They're less sedating and they have fewer drug-drug interactions. Other medications, so valproic acid has actually been looked at as treatment for alcohol withdrawal, but only as an adjunct. So this is not something that you would ever use for monotherapy, only as an adjunct to benzodiazepines. It's not appropriate for women of childbearing age or potential, and not appropriate for those with liver disease. The alpha-2 adrenergic agonists like clonopine, again, only, or beta blockers, again, only appropriate as adjuvant therapy. And then I'm going to focus just a little bit on monitoring. So what are the goals of monitoring? Obviously, we want to look at the signs and symptoms and determine whether they're responding to the therapy that we've initiated. Do they have other conditions that may be worsening? Is there any evidence of oversedation? Are they able to follow the instructions when they're away from our setting? If not, that maybe they need to go to a higher level of care. And are there any other indications that would suggest that they need to be transitioned to a different level of care? In terms of the frequency of monitoring, ideally, we want patients to be monitored daily. Now, that doesn't necessarily mean they have to be seen in the office daily. Certainly, now we're in the age of COVID, we're doing a lot of teletherapy and telehealth. So if they can do telehealth visits, but the ideal is that they're monitored daily for at least up to 5 days. And we want to be assuring that they've got significant reduction or complete cessation of their symptoms, but then also their alcohol use. We also want to be monitoring other health conditions. And so, you know, what is their physical condition? What are their vital signs? Do they have, again, things to think about if you're going to be sending somebody home? Do they have the ability to check their blood pressure or their pulse at home? Can they stay hydrated? And certainly suicidality. So obviously anybody with suicidality is not appropriate for the ambulatory setting. What's happening with their alcohol use? Do they have other substance use? What's happening with that? Is that, have they been able to abstain from alcohol? If not, again, thinking about whether they may need a different level of care. What's the severity? Again, we want to make sure we're monitoring that with a validated instrument. And then again, what's been their response to treatment? Reasons that for which you might transfer somebody to a higher level of care. If their agitation or tremor has not resolved by the time, so if you're in a level 2 IOP and you've been given the medication and you've not seen resolution in these symptoms that may of their agitation or the severe tremor, then they probably need to go to a higher level of care. More severe signs or symptoms develop. If they have existing comorbidities, whether they're medical or psychiatric, that worsen, whether or not their alcohol withdrawal signs and symptoms improve. If the other conditions worsen, then they may need to go to a higher level of care. Certainly, if there's oversedation, again, if they're unable to control their alcohol use and are continuing to drink, and then any evidence of clinical instability. And then the last thing I want to highlight is that withdrawal management should be, it's not a treatment in and of itself, it should be the beginning of treatment. And so when feasible, we should initiate treatment concurrently with our alcohol withdrawal management. And that's again why if you are able to do it in a level 2 setting where they can get on-site counseling and therapy while their alcohol withdrawal is also being managed safely, then by all means go ahead and do it. So in summary, key takeaways, the guideline process was a multi-year iterative process. When you're assessing patients and determining level of care, that assessment should really focus on what are their current signs and symptoms and what are their risks for progressing. And you should be using a standardized assessment tool to assess the patients. Benzodiazepines remain the medication of choice, but GABA-sensitive anticonvulsants are definitely viable options for people with mild to moderate alcohol withdrawal syndrome. Proper monitoring is essential. And again, initiate treatment for their alcohol use disorder as early as possible. So I just want to acknowledge the ASAM staff for most of the content of these slides. And I just want to remind everybody to treat addiction because it does indeed save lives. So I will stop sharing. Okay, so I'll pass it on to the esteemed Dr. Hurley.
Dr. Hurley, are you on mute right now? I think we're having a little bit difficult.
Can you hear?
Yeah, we can hear you.
Can you hear me okay?
Yeah.
All right. Hey, just as a quick process step, there were a couple questions that came in. Should Anika address those now, or should we wait till the end?
I think we can wait till the end.
All right, sounds good. We'll wait till the end. And sorry about the audio issues. If there's any other audio issues, just chat in. Thank you, Anika, for chatting in. If there's any other issues, chat in and I'll address them. So hey, everybody, I'm Brian Hurley. I'm an addiction psychiatrist, and I live and work in Los Angeles. I am the director of addiction medicine for the Los Angeles County Department of Health Services. And I'm also on the board of ASAM as a director at large, and I don't have any conflicts of interest to disclose. So I want to talk a little bit about a real world application of the ASAM National Practice Guidelines for Alcohol Withdrawal Management. And this is in the context of COVID-19. So COVID-19 has done a few things. One of the things that it's done is increase stress, anxiety, and isolation. It's had economic impacts. And these we think of are drivers of worsening addiction and the drivers of stress that worsen addiction. And you actually notice that there are now rising opioid overdose rates. That is, some of the progress that was made with reduced opioid rates pre-COVID has essentially been erased, and that we're seeing more opioid overdose. And in this context, we're actually pivoting to deploying addiction treatment technologies in ways that are novel, typically ways that are remote, right? So given that having a patient come into your office and providing a biological sample like a urine sample or a breathalyzer sample is no longer as benign as it would have been, say, pre-COVID. So so we're in the position of, we rely on best practices, but we're now adapting them. And there's been rapid change in guidelines. So, whereas before there've been some rigidity around the in-person evaluation and physical exam needed to start controlled substance, particularly medications for opioid use disorder, there's now been some relaxation and permissibility of using telehealth and telephone options to initiate treatment. I just want to highlight, there's guidance and guidelines, right? So there's been a lot of guidance that ASAM has offered, but really the National Practice Guidelines was one of the most recent guidelines that came out in the context of COVID. And as was mentioned, the guideline timeline for release of the guideline, which is generally a year plus process, many years process, was sped up. So there's the early phase of COVID-19 pandemic. I think we might be heading towards or in the middle phase where we're seeing higher population prevalences doing our best to try to limit the transmission of COVID-19. And then post-pandemic, we're going to see implementation of best practices. So the alcohol withdrawal management guidelines were released. And in Los Angeles County, we're faced with a large number of unsheltered individuals residing our community here in LA, and unsheltered individuals that, if you say isolated home, where home is actually can mean a lot of different things. And so we launched an on-call addiction medicine consultation service very quickly within less than a month of COVID-19, where anybody in the county system can call for addiction medicine intervention. And we created quarantine and isolation sites for people who were symptomatic with COVID, and field housing sites for people who needed a place to isolate. But one of the challenges is if you're going to take a population of people where the substance use prevalence is relatively high, and you're going to put them in a quarantine site, and they don't have access to alcohol, you're going to need to treat alcohol withdrawal syndrome. And so we built essentially an expected practice around this. And I'm not going to recover everything about alcohol withdrawal syndrome, but I do want to highlight that the hallucinations and the seizures tend to precede the heavy autonomic dysregulation, irritability, tremors, and disorientation that's characteristic of alcohol withdrawal delirium. So we tend to see seizures and hallucinosis first prior to more severe withdrawal syndromes. And in terms of severity, we know that history of recurrent detox and prior seizures are risk factors for worsening alcohol withdrawal. We know that the alcohol withdrawal tends to occur within a day of abstinence or decreased intake of alcohol, and seizures actually occur prior to autonomic activity. So the ASAM National Practice Guidelines, talk about symptom-triggered benzodiazepines and fixed-schedule benzodiazepines. And, benzodiazepines have a really good risk-benefit profile, generally speaking, in terms of their therapeutic window, and are strongly effective at preventing seizures and also delaying the progression to more severe alcohol withdrawal syndrome symptoms. Phenobarb is also a decent option, trickier to dose because that therapeutic window is less. And there's a number of anticonvulsants from carbamazepine and gabapentin. And valproate was not recommended as a monotherapy treatment, but gabapentin and carbamazepine were both considered as anticonvulsants that could be considered for monotherapy treatment for mild withdrawal. And then there's a bunch of other things that are evidence-based but weren't recommended in the guidelines. So these were non-benzodiazepine anticonvulsants that were considered, and there's a whole bunch of other, there's baclofen, clonidine, dexmedetomidate that have a role as adjunctive agents, but generally not as monotherapy. But I was faced, or we in the county, but I as the director of addiction medicine was faced with a question. If you have a whole number of people who are isolating at home, do you then pass out a whole bunch of benzodiazepines? And actually what we can conceptualize is, benzodiazepines, while being safe from the perspective of good therapeutic window, good prevention of seizures, and helpful at the prevention to more severe withdrawal, we were concerned that passing out benzos as first line to a set of patients with alcohol use disorder comes with other risks. So I pulled this up. This is not in the guidelines, but I pulled this quote from an article that sort of stuck with me. And it was, despite their proven usefulness, which there's no doubt benzodiazepines have a strong role as a first line agent, their use in ambulatory settings is fraught with complications. Now, it's not that it can't be used, but it really depends on the patient. How strong is the therapeutic alliance? Was the patient in a position to check in? Is the patient in a position to transport themselves to a higher level of care, like in the emergency room, if needed? And benzodiazepines do blunt cognition. They do have respiratory and other cognitive interactions, although I don't withhold them from people on methadone. So I will give benzos to people on methadone, but again, if I know I'm going to be able to see them, right? If they're going to continue to come into the methadone clinic, I'm going to be able to continue to see them. They do have interactions with other CNS depressants, and there is psychomotor retardation, so they're not totally benign. And so we developed an expected practice, and this is our clinical care library. And we said, step one, diagnose and determine the severity of alcohol withdrawal syndrome, to use the SAS or the CWA, but you don't actually have to document the score. One of the things where in a county system where we get hung up is, well, I don't have the form. Well, if you don't need the form to diagnose alcohol withdrawal, right? Like you should, and if you don't know what alcohol withdrawal looks like, then look at the form and look at the symptoms. But we don't necessarily require every clinician to document the actual score. Know what your scale is, know the difference between mild, moderate, and severe, but we don't necessarily make the step of everyone has to use the same form and document the specific score on that form every single visit. And we have a list of anyone who's had a history of alcohol withdrawal delirium, any acute illness, any severe cognitive impairment, or inability to take oral medications really does need to go to a higher level of care. But to order labs, because labs can inform severe illness or other etiologies that might complicate alcohol withdrawal management, but don't withhold medications for alcohol withdrawal management. Then step 3 is to initiate first-line pharmacotherapy for alcohol withdrawal. And we're actually saying in our county and in our ambulatory sites that unless somebody has a history of severe withdrawal, if it's otherwise sort of agnostic alcohol withdrawal syndrome or mild moderate alcohol withdrawal syndrome, to start with gabapentin. So we're recommending 1,200 of gabapentin BID plus 1,200 times 1. So it's sort of 1,200 TID up to 1,200 TID day 1, and then 600 TID to QID starting day 2 through 7, and then kind of a relatively abbreviated taper off during days 8, 9, and 10. If you add this all up, it adds up to about 30 600 milligram tablets, which can be split. And these are the instructions that we put out. And I'm happy to share this slide deck if anyone wants to or send you the EP if you want to see what the expected practice looks like. And for patients who don't tolerate gabapentin or don't respond, carbamazepine is an option, although truly if somebody's a non-responder, they should be offered benzodiazepines. But one of the reasons that we're starting with gabapentin and carbamazepine is they were recommended as monotherapy by the National Practice Guideline for mild withdrawal. And if you screen out anyone that you know is going to need benzodiazepines and might need to go to a monitored setting or a more structured ambulatory withdrawal management setting, that they could reasonably offer relief from and help prevent the progression of alcohol withdrawal syndrome without the patient needing to go to a hospital or enter a ambulatory withdrawal management program. So with carbamazepine, it's relatively straightforward. 200 QID for 3 days, 200 TID for 3 days, 200 BID for 3 days, and then the last 2 days is 200 milligrams at bedtime, which also works out to 30 of the 200 milligram tablets of carbamazepine. And because not all of our patients in LA County have high literacy rates, we have a handout. So this is our gabapentin handout that literally says, morning, afternoon or midday and evening, and how many pills should be taken at each time. This is the gabapentin handout, and this is the carbamazepine handout. Now, so that's alcohol withdrawal syndrome in a nutshell. But alcohol withdrawal syndrome, yes, sure, you can use, and then we actually, for our quarantine sites, have protocols for when to escalate to benzodiazepines and how to do that. So you don't necessarily have to send a patient who's quarantined due to COVID to another healthcare setting to potentially spread additional COVID. That at some sites we are equipped to do ambulatory withdrawal management, but not at all of our ambulatory sites. So this is first line, and then for our quarantine isolation sites, we built in fixed dosing chlordiazepam epoxide or lorazepam protocols according to the ASAM National Practice Guideline. But it's sort of steps, like start with anticonvulsants, then go to benzodiazepines depending on the severity of the case. And if patients really do have a history of severe withdrawal, then benzodiazepines remain first line. But none of this actually treats alcohol use disorder, right? If you're having alcohol withdrawal syndrome, the positive predictive value you're going to have alcohol use disorder is pretty high. And we have meds and counseling and support available for that, just in general. So I do want to say, the next step of the alcohol withdrawal management protocol is the use of medications like naltrexone or camprosate. We're not using a lot of disulfiram in patients that are high risk of drinking because patients are at high risk of drinking. But these medications do seem to affect alcohol cravings and reduce use. The number needed to treat is relatively high compared to other agents, but nonetheless, camprosate and naltrexone do have a role in helping prevent and reduce return to drinking in somebody who's stopped. And disulfiram can too. And there's good evidence in daily observed therapy or DOT protocols. Now, it just so happens in California, we don't have a camprosate on our Medicaid formulary. So we've been using actually a fair amount of topiramate, which is an off-label, so just off-label, generic. I'm not working for any drug company, but topiramate is an off-label agent. But gabapentin also has a role as a maintenance treatment for alcohol use disorder. Generally speaking, not as a monotherapy, but in addition with something else, gabapentin is perfectly reasonable. And then there's some mixed results for things like baclofen and ondansetron. But we're using topiramate in non-pregnant patients who can tolerate a high enough dose for it to be effective. Just a quick note about oral naltrexone. It does, in terms of who goes back to drinking, it does increase the chances of reduced return to heavy drinking from 37.5% in most populations to 48%. And Project Combine is like the big study on that showed that meds are effective and counseling is effective, and the combination of meds plus counseling did not seem to have much added benefit, but they both can be, so you can prescribe naltrexone even if a patient won't go to treatment. And this is just side selling that same thing. So our step 4 is to treat alcohol use disorder. And we have an alcohol use disorder expected practice, and then refer to specialty substance use disorder services when the patient's ready. So it's, diagnose alcohol withdrawal syndrome, do a workup, offer first-line agents, anticonvulsants for alcohol withdrawal syndrome, and triage patients that will need to go right to benzos or benzodiazepines. And for patients that break through anticonvulsants, they also get to benzodiazepines. Don't forget to treat alcohol use disorder, and then refer patients for specialty services when necessary. This is our naltrexone handout. It's relatively straightforward. It's 1 pill a day. If you're sensitive to naltrexone, you start with a half a pill for a few days and then go to the full pill. But there's an alternative way of delivering naltrexone to people, which is naltrexone long-acting injection. And if you look at drinking behavior over time, those that receive naltrexone long-acting injection return to drinking less than people that don't, and return to heavy drinking. This was the last slide was heavy drinking. And this slide is any drinking at all. And if you look at it just over time, those that get naltrexone long-acting injection tend to drink less. So there's a few contraindications to naltrexone long-acting injection, like people who are on opioids or of any source, or people on acute opiate withdrawal. but it's a medication that doesn't require an oral lead-in, and is also a reasonable option if the payer will pay for it and you have access to it. Again, in LA County, we launched a 7-day-a-week consultation service to help guide our colleagues who might not be familiar with the use of anticonvulsants for alcohol withdrawal syndrome, might not know the national practice guidelines on alcohol withdrawal management, might need help in using medications for alcohol use disorder, or parenthetically opioid use disorder, because not everyone that I work with is X-waivered. So, this is a service that we created. And that's, I think I went a little over 10 minutes, but that's my time. This is my county email address. It's bhurley@dhs.lacounty.gov. And I'm in California. We run a national meeting in California. So come to the CSAM annual meeting. The ASAM annual meeting is coming up, and I am also a psychiatrist. So there's an addiction psychiatry meeting coming up. So thank you so much for, I know this was a quick, but I did want to talk about the practical application of a national practice guideline in a setting and what we did in Los Angeles. So should we take questions now?
Yes, I think we can go ahead and take questions. And since you just finished, and it looks like there was one question that was specifically directed to you, Dr. Hurley, if you would like to go ahead and answer it before we go back to the other questions. But the question was—
yeah. Go, please.
Can you use IM naltrexone in a patient who does not tolerate the PO formulation due to the GI side effects?
Yes. So because oral naltrexone goes directly through the liver, the GI side effects of injectable naltrexone are thought to be less. They're not zero, but they're conceptualized to be less. And so you can use IM naltrexone in a patient who can't tolerate the upset stomach, because IM naltrexone tends to cause less upset stomach than oral naltrexone. The flip side of that is that injectable naltrexone does have a pretty high naltrexone blood level during that first week. And there's something called like the naltrexone flu that can happen during that first week. It usually is only during the first injection, but it's something I warn patients about. You could sometimes have a headache and, kind of feel just low energy and kind of like you have the flu. It's not COVID, right? And it almost always is just during that first week after that first injection. It almost never recurs after the second or third injection. So that's something I sort of warn patients about. And then, I had this one patient, he called me, he's like, I'm never taking naltrexone long-acting injection again. And then 3 weeks later, he's like, but I'm not drinking 2 bottles of wine anymore, like every day. Like I'm feeling better, I'm drinking less. And he didn't stop drinking, but he was drinking a lot less, and he felt better enough that it was worth it for him to take the second shot. So it is possible to treat somebody with injectable naltrexone even if they couldn't tolerate the GI side effects.
Thank you for that. Another question that was directed specifically to you was, if gabapentin was to be continued for alcohol withdrawal syndrome and as a treatment for alcohol use disorder, how long would you usually continue it, and would you need to taper it at the end of treatment?
So with most maintenance medications, usually I am tapering towards the end. So that would be true for naltrexone. Gabapentin, which was the question was about. So yes, I would, if I had somebody on a gabapentin maintenance treatment, I would taper it towards the end. It's not universally, it's not like a benzo where like if you taper, the patient's going to seize. But generally, patients tolerate the taper better when you taper it. And if anyone does have epilepsy, you can have breakthrough seizures if you come off gabapentin. One of the questions was, 400 TID for outpatient withdrawal, and patients don't, you don't either might forget to take it or take a TID. This is why I tend to do higher doses, right? Because even if they only get 1 or 2 of the 1,200 doses, I'm getting better overall coverage than I would have as otherwise. And there's no actual, sometimes people ask, how long do I need to make gabapentin? Not a day longer than necessary. We'll figure it out together. So I use it typically adjunctively with another medication for naltrexone. I have some patients on maintenance gabapentin. They've been on it for years, and they find that it helps reduce their drinking.
Perfect. And another question is, can you just generally address any concerns regarding pre-op preparation of surgical patients and post-op management that have alcohol use disorder?
Don't use naltrexone if somebody's you think you're gonna need opioids perioperatively. So wait, schedule the surgery if possible. And then for gabapentin or carbamazepine, both of those things can be used perioperatively. If somebody's, truly, I mean, most people that are undergoing surgical management are going to be under you're going to have some anesthesia, you're going to have some monitoring. And in those cases, I think benzos would be preferred because you're going to have somebody who's there monitoring the patient to make sure that they're, responding okay and that they're breathing okay. So I have a low threshold for using benzos in any kind of monitored environment. So I would probably just go right to the benzos for alcohol withdrawal management.
And would you?
I know that was a whirlwind. Thank you for tolerating the speed.
No, I think you answered the question very succinctly. But when somebody is on the long-acting naltrexone and they are preparing for surgery, do you just wait the 30 days until the medication is out, or do you?
I wait the 30 days. I mean, the one alternative is you can put people on things like standing acetaminophen and standing ibuprofen. I mean, this depends on is somebody's liver intact? Is there, a kidney function? Okay, right. This is assuming everything else being equal, that there's no contraindication of things like acetaminophen. You can use 1,000 milligrams of acetaminophen Q6, staggered every 3 hours with ibuprofen 600 Q6, so kind of max out acetaminophen. If you start that, don't give it PRN, but standing acetaminophen and ibuprofen, you can get decent analgesia that works sort of perioperatively. But I'll say the standard guidance that I give my patients on naltrexone long-acting injection is to schedule the surgery kind of in between shots. Because depending on how painful the surgery is going to be, there are patients, even patients with substance use disorders, there's a role for opioids in pain management for acute pain, and so I wouldn't want if the patient did have a terrible pain response to the surgery, that their pain would be untreatable because they've essentially got the naltrexone blockade.
Perfect. And this question could be for you, Dr. Hurley or Dr. Alvanzo, but of course we know that alcohol use disorder is a chronic condition with, recurrences of substance use. Do we know much about longer term outcomes after alcohol detox in these patients?
Yeah, the relapse rate after detox is 100% unless somebody does any kind of treatment. I mean, forgive me for not knowing the number, but unless somebody does treatment, their return to drinking is very, very high.
Right, and I think that's why the guidelines really emphasize that you don't have to wait until you complete the withdrawal management before you initiate treatment. Because again, essentially, it's almost not greater than 90%, I would say.
Yeah, it's really high.
And then there were a couple questions that were posed during your presentation, Dr. Alvanzo. The first one was BAWS, the Brief Alcohol Withdrawal Syndrome Assessment. It was specifically done in a hospital setting. How could that be helpful in an ambulatory setting for withdrawal management?
Yeah, so I can actually say that the BAWS was developed in the hospital setting, but it's actually used in the freestanding outpatient withdrawal management unit on the Johns Hopkins Bayview campus. So the reason we created the BAWS, because it's based on solely objective criteria. And so, with the CWA, it has a lot of subjective symptoms that you're asking about. And obviously in the acute care environment, once somebody gets to higher levels of care, or if they're become intubated for some reason, you can't rely on subjective symptoms. And so we developed the BAWS to be an objective tool that had objective measures, but it has been tested. We tested it against the CWA, and it's used, as I said, in the alcohol withdrawal management on the Bayview campus. So it's used not only in the acute care setting, but in the, I guess there would be considered a 3.7 level withdrawal management unit, and they're using the BAWS there. In the ambulatory environment, again, I think because it's an objective tool, I still think you can use it in an ambulatory withdrawal setting.
Perfect. And a couple other questions. The term oversedation has been used, but isn't any sedation basically oversedation?
Yeah, so I mean, I think again, and again, the guidelines were developed for both the ambulatory withdrawal setting and also the inpatient setting. So in some instances, particularly when people have progressed to some more severe levels of alcohol withdrawal management, particularly if they're getting to the point of alcohol withdrawal delirium, then you do want to have some sedation. In the ambulatory environment, yes, you are very concerned about sedation, and you may have to, again, that's what we want to assess. You may have to have patients back off on their medication, but again, that's why determining whether the patient is going to be able to follow your instructions. Is there somebody there that can also help them in their assessment? Are they in an environment where they're going to be able to access their medications and control the access to the medications? All of those factors go into play when you're determining whether somebody can be safely managed in an ambulatory environment.
Perfect. And has outpatient alcohol withdrawal management with benzodiazepines been studied in populations with individuals that have a concurrent opioid use disorder and or are on medications for opioid use disorders?
So I would say the majority of the studies that were in the published literature often exclude patients with other severe withdrawal syndrome. So often, sometimes you get the pristine research population that doesn't necessarily, or research sample that doesn't necessarily mirror what's happening in many of our clinical practice environments. But people are using, I have used benzodiazepines in treatment of patients with opiate use disorder. Again, I had the luxury of practicing in an acute care setting for many years, and so I was able to do that. Again, I think in mild to moderate, if somebody has a mild to moderate withdrawal and you are comfortable with their ability to monitor, I don't think it's unreasonable to start with one of the GABA-sensitive anticonvulsants first. And kind of like Brian described in his presentation. But I wouldn't say it's an absolute contraindication. There are some people for whom who have an opiate use disorder and are concomitantly on buprenorphine can be treated with benzodiazepines. Similarly, as Brian mentioned, patients on methadone can be treated with benzodiazepines for their alcohol use disorder. Again, you have to determine whether you think that patient is appropriate for the ambulatory environment. And some of them can be.
Perfect. And it looks like the last question is, has the Sinclair method for alcohol use disorder been totally rebuked, or is that a validated evidence-based treatment for alcohol use disorder?
So I am not familiar with the Sinclair method methodology, so if you can tell me what that is, then I can tell you what
Dr. Katz.
All right, this is Paul Katz. Titrated alcohol administration as a chronic adjuvant through.
Yes, yeah, that was absolutely, there was a clear definitive statement in the guidelines that alcohol should not be used for management of alcohol withdrawal syndrome.
This question was posed by a neurologist who is an active alcoholic, who was quite insistent that we at least attempt to treat him thusly. It was very challenging.
Yeah.
So we have that as a written guideline. Is that in our literature?
There is in the guidelines. There is a statement that says alcohol should not be used for treatment of alcohol withdrawal syndrome.
Right. Okay.
My understanding of the Sinclair method is essentially taking an opioid antagonist just before you drink every time. So you're taking naltrexone before you drink, and the idea is that it would decondition the rewarding of drinking by blocking opioid receptors, which is a little different than taking it on a daily basis like you would naltrexone. This method just says take it before your first drink of the day. And I don't know much about the success rate of that type of way of doing it.
So I can speak to that. I do this Sinclair method quite a bit. It's related to, sometimes people call it targeted use of medication. There's a lot of literature about it. It works, but it only reduces craving. So so the idea is that if you continually use the naltrexone faithfully every time, an hour and a half before you drink, the naltrexone blood concentration is maximum at that time, and it will actually reduce your consumption because you don't get the euphoric effect of the acute alcohol ingestion. And Sinclair found it worked with rats. Over time, they've reduced their consumption, and it works with people. There's a lot of data that shows it does, but it doesn't have anything to do with alcohol use for withdrawal per se. Although my patients will generally go, takes on average maybe 6 months to go from drinking a couple bottles a day to 0. And there's no need for withdrawal at that level. So no, it's there's a lot of data on it. It's not well understood, but it's when you take a look at the pharmacology of naltrexone, of course, the peak blood levels are at an hour after you take the pill. So if you drink an hour after you take the pill, you're going to have the maximum blood concentration, so you have the maximum effect of the naltrexone. You can, people have, there's a nice review that Sinclair did a number of years ago.
I'm just showing my age, I guess. But thank you.
Yeah.
Perfect. Thank you all for adding to that discussion, but also thank you for staying with us. And we're going to start our small group conversations now. They're going to run for about 10 minutes. And so we just want everybody to introduce yourselves in the breakout rooms and kind of share what you learned and how you plan on applying tonight's guidance in your practice. So we'll see you in about 10 minutes. Okay, I think everybody is back from their breakout sessions, but once again, I just want to thank you all for joining us tonight. We will be sending up follow-up resources to all participants later this week. But before we head out, I just wanted to let you know about a few things. MedChi is coordinating all clinician calls with Dr. Howard Half of the Maryland Department of Health on COVID-19 every Wednesday. And to register for a call, visit our resource space online at www.mddcsam.org/resources/COVID-19. Also, our education committee will meet in a couple of weeks to discuss upcoming educational events. So if you're interested in participating, you can let us know by responding to your post-event email or contacting us at info@mddcsam.org. The post-event email will also include a link to complete your evaluation for this event and get your CME certificate. Finally, we'd like to encourage you all to visit asam.org. Our national organization has created a robust and timely resource center with critical guidance for addiction specialists. And once again, thank you to our speakers, Dr. Alvanzo and Dr. Brian Hurley. And I hope you all have a great rest of your evening. Good night.
Good night.